Good morning, everyone. My name is Scott Belliston. I'm one of the PGY4s in neurology, and I'll be presenting this morning's case. So, the case I'll be presenting is a male octogenarian who came into the ER stating that just 90 minutes prior to his presentation, he was unable to walk after he slumped over climbing up the stairs. He came in with left-sided weakness. He was also complaining of left facial droop and drooling. Family members said that his words were, he was slurring as well compared to how he'd normally talk. So some of his past medical history, he has chronic left eye blindness from a childhood injury, hypertension, hyperlipidemia, GERD, and BPH. October 2013, he came to KU after having witnessed a generalized seizure, tonic-clonic. He was noted to have fevers at that time and right temporal lobe subacute stroke. He was treated in the neurological ICU. He received antibiotics and was placed on Keppra and was discharged home at that shortly thereafter. And then was just following up in clinic until the end of May when he again presented to the KU, and this time he also had a generalized seizure and was noted to be in status. This was thought to be, his breakthrough seizure was thought to be due to recently decreasing his Keppra in the outpatient setting, as he hadn't had any seizures, and that he had recently started tramadol for joint pain. And then after he was discharged in May, family states by going back up on his Keppra back to 1,000 BID, he had not had any seizure-like activity at that time to presentation when he came in with the left hemiplegia. So on exam, he was awake, oriented to self, place. He was afebrile. His blood pressure was 150 over 107. He did have moderate dysarthria and some mild expressive aphasia noted. His cranial nerves did show a left lower facial droop at that time. And on motor, he did have flaccid hemiplegia on the left with some difficulty with right arm and leg movement as well, some drift on that side. His sensory was intact to pinprick, but he did have extinction on double simultaneous stimulation on the left. At that time, his NIH stroke scale was 14, but some of that was for the right-sided drift.
Did you do other things like graphesthesia? Or?
Not at that time, no.
So, this stroke epilepsy case, Dr. Demarch?
Sounds like it.
Not neuromuscular,
right?
I thought it was going to be some neuromuscular case. Where's the lesion?
I would guess somewhere in the distribution of the right MCA.
Oh, more specific than that.
Okay. Is it like subcortical?
Why?
Because he has some dysarthria. He has weakness as well.
Well, you can get both those with cortical too. So what would make it subcortical?
I guess he can be cortical as well.
But I mean, what in this particular case, what would point in favor of a subcortical lesion? Any other reasons? It's essentially pure motor. I mean, except his 2-point
Double simultaneous.
Yeah, his double simultaneous stimulation. But he doesn't complain of sensory symptoms, and he doesn't have any sensory signs except for that one subtle parietal lobe sign, which could have been left over from the old stroke, so you don't know. So because it's pure, maybe pure motor, it could be subcortical. Subcortical where? What subcortical structure? Internal capsule, corona radiata. Or it could be a cortical event with just not a whole lot of sensory. So how often are we right, Dr. Wang, on making that call at the bedside of cortical, subcortical about 50% of the time?
Yeah, I think, I mean,
Not much better than that. Something like that.
That's too easy to say it's a stroke. What else could it be?
Well, we haven't gotten there. I haven't said it's a stroke. That's where's the lesion.
That's why you said, started by saying stroke or epilepsy.
So what could it be other than stroke? What type of stroke could it be? Is he on aspirin?
He does. He takes 325 aspirin. He takes Keppra 1000 BID, and he's on simvastatin.
So 2 strokes in a year.
How long has he had a seizure disorder?
It was his first seizure was in October of 2013.
First stroke.
That's got to be pretty rare, isn't it?
It's
80-year-old.
odd to have. Well, no, he seized with his first stroke,
Oh, okay.
and then he re-seized 6 months later. So the seizure with first stroke is rare, unless it was a hemorrhage or something. So it could be a hemorrhagic stroke again, maybe got amyloid or something like that. 2 strokes, but it's a little too anterior for amyloid. Anyway. So what else could it be other than ischemic or hemorrhagic stroke?
Isolated seizure.
A what?
A seizure.
This episode? They didn't see any seizure activity, did they? With this episode?
On presentation, no. He slumped over on the stairs and was flaccid on the left.
Could that be seizure activity?
Sometimes with the negative symptoms, you can see.
Pretty rare though.
But I missed the first part. Yeah, it's really rare, and I missed the first part. How long was it?
He presented 90 minutes into his symptoms. So left facial droop, left flaccid.
He's not like a stroke.
You know, it's really rare, but I can
But
say
he's got a
it's not gonna
seizure.
happen.
But he's got a seizure disorder. So what else?
It could be he might have had a seizure, and then he might have had some kind of paralysis.
Where else do you want to lead him to, Dr. Dubinsky?
Well, none of his diseases protect him against the subdural or brain tumor or abscess or things like that, any other mass lesion.
Okay. All right. What you got?
Well, so I kind of kept it simple because he came in with stroke activated and he was in a TPA window. I
Why do
thought
you guys always focus on territory rather than actual lobe of the brain? That's some stroke thing, isn't
it
it?
is, yeah.
Yeah. Okay.
So at that time, I was wondering whether or not is he a TPA candidate, and wondered what you guys thought.
When you say right MCA territory, did he have any phase neglect?
No, he didn't. He had no cranial or no full extraocular movement. So
It's not a full territory.
no, not the full
It's
territory,
on
but
branch distribution.
That's why I don't like the term MCA territory. It's just like saying it's a brain problem, Dr. Wine. I mean,
that's a
you
how.
have 3 choices: MCA, PCA, or
Yeah, that's
ACA.
how much.
So it's a little.
We do macro. We do not.
That's pretty
do,
macro.
Yeah, we do macro. We do not do micro. So I think if we can separate the brain from a neuromuscular junction, it's pretty
good
good.
day.
Yeah.
This is all being taped, you know. All right.
Scott mentioned some problems with the right side, drift on that side also. So there's some evidence of something bilateral.
Yeah.
The question is what's old and what's new. Do you know what his baseline is?
So family was there, and they gave a good history. His daughter and wife were there when he fell on the stairs. They said earlier that day he was eating, talking normally. He's been walking around. He recovered fairly well from his stroke.
You're diffusing the issue, Dimash. You just want to avoid, do you get TPA or not? With this neuromuscular doctor, TPA, the situation.
At 90 minutes, I would like to see a CT angio. And his age
First?
is variant. You know, I would just not care for the age. I would just push through.
So if there's no bleed, you give him TPA.
Well,
Yeah.
so far, you haven't shown us any contraindications to TPA.
Well, so relative contraindications. He's had a previous stroke, but it wasn't in the last 3 months, but they're more likely to bleed after having a previous stroke. He's 87. the studies haven't really tested people over the age of 80. And
Young 87, so that's
yeah, I mean, we do look at function. That's true. But he is has a higher intensity to bleed with the increased age, and then his diastolic blood pressure was 107. So yes, absolutely. But just things to consider: is he a good candidate? Is how likely is he to have hemorrhagic conversion?
So the residents are closer to this than Demachki and I. So is there a resident who would not give TPA? Is there other than given all the caveats he said? No? All the residents would give TPA. Kendi?
I don't think you necessarily have to.
Well, I'm asking them.
Yeah,
Is there anyone who wouldn't?
Well, okay, I'll play that side. And the margin of benefit of TPA is slight, it's not absolute. People get off the table after getting TPA, it's a TIA, it's not a stroke. Benefit from TPA, the NIMDS trial was at 90 days, not at 24 hours. So the chances are, yeah, he may be a slightly higher Rankin's level if he gets TPA versus placebo. But he's
That's a
otherwise-
philosophical argument for TPA or not in any patient.
But if you solve for the family, yeah,
So you sound like an ER doc.
more therapeutic mileage. I was trained by Stanford Health.
So what does the stroke service do in this case, Dr. Wang?
I think, just as Scott said, the patient onset, apparently it's weakness onset on the 90 minutes. And there is really, if you look at TPA contradiction, age is not a criteria. Definitely, if you add everything together, his risk of bleed probably slightly higher than the study 3 to 5%. I think we need to definitely explain to the family. And just like everybody realize this is just a hard case. And, patient had a history of a stroke. Patient also had a history of a seizure. Actually, his first seizure his first, stroke presented with a seizure. So, could this is a seizure present with negative symptoms? I agree. Seems this 90 minutes is just too long. But then later developed something else that will help us sort out.
Exactly. Nice segue, Dr. Wang.
later, you don't have a lot of time.
Actually, while Scott on the phone with me said he's jerking.
Yeah. So right
Okay.
as I'm calling my attending, wondering not whether we should give TPA, the patient started having bilateral extremity jerking, but he was able to talk through it. It was really kind of bizarre. It was rhythmic jerking of his lower extremities, upper extremities, but he was able to follow commands. But shortly after that, of course, as it usually happens when the attending arrives, he was only jerking on the left side. So he was more a simple partial seizure at that time. But, we did want to use additional testing to see, could he have stroke and seizure. So like Dr. Demachki mentioned, CTA would be helpful. We actually did a CTA and CT perfusion on him. We'll go through. Not sure how well this is going to come across, but
Those lights, if they can go down.
I don't know if I can change from that.
That knob.
I'm really showing there's a lot of knobs. Oh, back here.
There you go.
Already has been.
not sure that's helping much, is it?
So tell us what you see, or Dr. Blatt, you can comment. I'll see the other radiologists who can take these.
Looks like the cerebral blood flow.
So far, I think it's down on the left, a little bit temporal lobe, but
And that was our thoughts, that maybe it was a little decreased.
Tell us that. No, I guess you have another one.
So, I mean, you can see the asymmetry between the two, and it looks like there's hypoperfusion here on this left hemisphere.
Wow.
Mm-hmm.
Or you may see hyperperfusion in the right.
Mm-hmm.
It's a seizure?
Yeah.
Well, actually, there might be some hyperperfusion on the right, but way down in the temporal lobe, it was really quite down on the left.
Hemiplegic on the right.
Yeah.
No, hemiplegic on the
On
left
the
side.
On the
Right
left.
aphasia. His stroke was on the right a year ago,
Yeah.
and he's not presented with a new left hemiplegia. Some resident said was seizure, and I said it's impossible.
Again. Some asymmetry and either the hypoperfusion on the left or hyperperfusion on the right.
Is this the same one you just showed?
No, that looks like transit time.
Yeah.
Yeah, this is time. So.
Front asymmetry.
Mm-hmm. This one.
Is this the test you wanted, Dimash, or you just want a regular old CT and CT angio?
So CT had showed his old right temporal stroke
It's time to
and didn't show any hemorrhage or acute process. CTA did not show any large vessel occlusion. So then we did the CT.
Here?
This is
Time to drain.
time to drain.
Yeah.
Yeah. So you're looking, if there's any stasis of blood here. Again, you see the asymmetry, and originally our radiologist read as the hypoperfusion on the left side, taking everything into account, with a 50% penumbra. But what do you do with that information? He's not having symptoms on the right; he's having them on the left. So you have to, think about what you're reading when you read a radiology report. They're not seeing the patient, so we know by his presentation that it's not left hemisphere problem; that it's a right hemisphere problem.
If you have a large infarct on the right, an old infarct on the right, that will affect its perfusion.
Mm-hmm.
To some
Absolutely.
extent, you might be seeing lack of perfusion in an area of an old infarct on the right.
Absolutely.
They try and make these studies, they're not quantitative studies, they're qualitative. So you can detect asymmetry, but if both hemispheres are down or both hemispheres are up, you can't tell any.
Exactly. And hopefully, if I have time, we'll talk a little bit about the limitations that are with that. A couple of the syndromes that I found that wanted to talk about, the hemiconvulsion hemiplegia epilepsy syndrome. This is usually in children, but it comes on after prolonged focal seizures of infancy and early childhood, and they get a cerebral hemiatrophy. But they will have usually before any hemiplegia, they will have clonic movements followed by the hemiplegia. So more like a Todd's paralysis. But there is the focal negative seizures that Dr. Uisal talked about that are also known as akinetic seizures, ictal paralysis, or somatoinhibitory seizures. These are pretty rare ictal events. I only found a handful of them through my literature search. And anytime someone presents like that, you have to consider that maybe they actually are having postictal paralysis, TIA, migraine, or and whether or not they're functional symptoms. They usually localize these focal negative seizures on EEG with PLEDs or spike and wave. I guess I didn't finish my sentence there, but spike and wave on the parietal, frontal regions. And then this is Dr. Todd who described Todd's paralysis. So, like a few of you mentioned, he may have actually had a seizure prior to his presentation, prior to his weakness, and then became paralytic. On the stair, going up the stairs. Yeah, probably unlikely. The family gives a really great history, so
It didn't sound like there was any.
no, family was there, but
Yeah.
So was this Todd's paralysis, or is this pre-ictal hemiplegia, or is it ictal hemiplegia? Hard to say because we didn't have any electrodes on him at the time. That's really how you make the diagnosis. So you didn't have an EEG at that time. How much time do I got?
Got about 3 minutes.
Okay, so a little bit about CT perfusion. Here's what we do with penumbra and infarct. The mean transient time and time to peak will be up both in the penumbra and the infarct, and cerebral blood flow will be down in both, but the cerebral blood volume is actually still increased in the penumbra or equivocal, and so we use this to know whether or not there's a penumbra or salvageable tissue to do further intervention without causing too much reperfusion injury. Some of the pitfalls that are involved with CTP, there's a lot of technical problems that you can have with it. You can have a penumbra without acute ischemia, and that can be from anatomical variations, that can be from birth, whether or not they have intercarotid stenosis or intracranial stenosis, if they have vasospasm or press, if they have a chronic infarct. Of course, we talked a little bit about the epilepsy and migraines that can do that, brain tumors. And then you can have false negatives. A lot of times you won't see lacunar strokes or small strokes or borderline or border zone infarcts. And CTP is really poor imaging quality for the posterior fossa. We really don't get to see those very well on that. So here's a normal example of a CTP, very symmetric. This next one is a completed infarct, so where it's completely matched. So there's no salvageable tissue there to try to intervene for. Here, this is showing penumbra, so possible ability to intervene. And here's a case like ours. You notice the DWI, there's no ischemia, but there's a mismatch here that may look like a left hypoperfusion, but it's actually a relative left hypoperfusion, and it's a right hyperperfusion during the ictal stage.
Oh, pretty rare, Ku. You believe it?
Yeah.
Would you like to hear an EEG? We're doing CT perfusion.
Yeah, we didn't hear about the EEG.
So you got the EEG after. So in the ER, we gave him Ativan for his twitching, and didn't get much better. He was already having the drooling. He was somnolent. We gave him some more Ativan, and he needed to be intubated. We sent him up to the ICU. His seizures resolved with having him intubated and starting on propofol. And so by the time he did get his EEG, it just showed diffuse slowing. Of course, we didn't get it during his activity. So.
Would have rather seen steady EEG than slow perfusion, but I guess
It's better with that person.
yeah.
Here am I.
I mean, even if they ordered an EEG, I would be before get an imaging to rule out a stroke before getting the EEG. So
Yeah.
down in there.
And things happened pretty quick. He was intubated right after his CTP, right up to the ICU.
Any comments, Shaw? That's pretty interesting.
Not much. I think the only thing is just as Scott said, all the tests help us make the clinical judgment, because we saw the patient. I mean, he's in CT scanner. He was seizing, that
Well,
side.
but I think the more interesting thing, I mean, obviously when he sees, what's going on. Interesting. How close was this guy to getting IVTPA?
Yeah, did he get to?
Actually, TPA was a drawer. TPA was a drawer.
Drawn up. The nurse was mixing
TPA was a
it.
drawer, and when Scott said he's jerking, I said, you know, let's do CPA, CPP.
Yes, it's the whole
Actually,
TPA.
when he said jerking, I said, let's do CPA, CPP. I just want to make sure this guy true have a stroke.
Yeah, well, I think that's, I mean, obviously this is a good phenotype presentation. It's also a decision-making thing. You can change your mind. You made the decision to get TPA, and obviously you had to change your mind quickly. So that was good. All right, great case. All right, we'll break for a couple minutes, then Mike Abraham's talking, I think.